Okay, good morning, everyone. Before I continue, just want to make sure that you can hear me right now. If you could type in the chat box. Perfect. Okay, so welcome to today's dental webinar session. The topic for today would be pharmacotherapy with Dr. Selby and Dr. Saunders. If you are interested in obtaining a letter of completion for today's webinar, you must have completed the registration and pre-learning assessment. Sign in to view the full webinar session using your first and last name and complete the evaluation and post-learning assessment following today's webinar. These webinars are being tweeted live. Follow CAMH Nicotine Dependence Services on Twitter at @PSQuitSmoking. And to follow the live tweeting or to post your questions or comments, use #TeachWebinar. And this is just a little bit of a biography on today's presenters. So Dr. Peter Selby is the Director of Medical Education and Clinical Scientist at the Center for Addiction and Mental Health, and he's a professor in the Departments of Family and Community Medicine, Psychiatry Faculty at the Dalhousie School of Public Health at U of T. He's the Executive Director and creator of Teach Project, and as well as the Principal Investigator of Ontario Tobacco Research Unit, Stop Study, and Adapt. Dr. Saunders is the Chair of the Oral Health Strategy for Ontario Dental Association, Editor-in-Chief for Your Oral Health, and an enthusiastic promoter of bridging dentally relevant topics to medicine. Our disclosures, Dr. Selby's disclosures, Dr. Saunders' disclosures. The Teach curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Contents of slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and discussion, set out only general principles and approaches to assessment, do not replace the need for clinical assessment.
Find a friend.
Okay, now before I hand it off, I'm just going to go a couple of polling questions just to gauge.
When you've gotten back your confirmation from people who have, say, you signed them up as East, do you phone them and give them the number to write down, or what do you do?
Conference is now in silent mode. All participants are muted. Press *1 to unmute your line.
Okay, now the first question is, what discipline do you belong to? Okay, and not surprisingly, 75% of you are dental therapists today. Okay. The next question asks, what region are you from? Okay, great. So it looks like the majority of you are coming from the eastern area, so Ottawa, Kingston, and so on. And the last question that we want to ask is, what type of organization do you currently work for? And about half of you are in private practice. So thank you for completing the polls today, and I'm going to hand it off to our presenters.
Good morning, everybody. Good morning, Debbie. Good to see you.
Good morning.
Okay, so our learning objectives identify the types of pharmacotherapy available in Canada for tobacco cessation. How can we apply an algorithm to help determine when and how to recommend medications for various levels of tobacco use amongst patients? And what are the risk benefits of pharmacotherapy with patients based on the best evidence? Moving right along. Can't seem to make this move. Oops. Okay, so let's start off with a case because sometimes cases help us. So we have Mary, who's a... Debbie, is this your slide or mine?
No, it might be mine. Let me do this, and then I think we're forgetting our colors, and I apologize for that as well.
I'm going to go ahead because I can't hear you. I think you're muted, so I'll just continue with it. Mary is a newer patient of yours, and she's recently moved to the area. She's come to the office for a new patient exam, routine clinic, has staining of her teeth as a main complaint and would like a teeth bleed.
She's not muted. She's connected to
Oh.
the computer. She said she can take it from here.
Okay, will you? Okay, 'cause I can't hear her.
No, I know, but she's through the computer.
Okay, all right, go ahead.
Sorry, Peter. Can everybody hear me just quickly? A 1-2 response there. Great. So today's webinar is co-presented by Dr. Selby and myself, and with a little bit of emphasis on case presentation. So you're going to see Mary a little bit later on in the presentation. But basically, this is a very routine examination. She's complaining of staining on her teeth, which is a common complaint in smokers. But obviously, the concerns for the dental professional usually expand beyond that. And we're noticing some advanced gum disease, some definite stain. And throughout the talk, I just want you to think about how you would gauge your conversation in approaching this patient and addressing her chief complaint, but also addressing the concerns that you have related to her dental disease. So looking at Mary, she's a 50-year-old divorced lady who smokes over a pack a day. She started smoking at a very young age, which is not uncommon. So doing the math, she has over 25 pack years, which we know is usually the crossroads at which most of our patients hit in developing chronic systemic disease, but also chronic oral disease. And Mary does have a chronic obstructive pulmonary disease, which is a smoking-related comorbidity. She lives alone, and she particularly smokes inside and in her car. And just thinking throughout today's talk on how we can address some triggers, changing the frequency of where she's smoking, how to address this. She also smokes with her coworkers. So let's just think about that as Peter continues with the talk. We're going to be talking about medications, and Dr. Selby definitely is an expert in the field in that. How do we approach and how do we address patients? Which patients are best treated with pharmacotherapy? Which patients would be amenable to nicotine replacement? And in some instances, pharmacotherapy and nicotine replacement. So, Dr. Selby, I'm going to let you go from here.
Okay, so the current medication options really are the two large groups. One is medications that are over-the-counter and nicotine-containing medications, and the others don't contain nicotine. The overall purpose, as we know here, is nicotine replacements, which include the long-acting varieties like the patch, and then the shorter-acting ones like gum, inhaler, lozenge, nasal spray, not available in Canada, and then the oral mist, which is available in Canada but not in the U.S. Other medications include Bupropion, also known as Zyban, nortriptyline, clonidine, and Varenicline, known as Champix in Canada, and Chantix in the U.S. There are several other medications under development, sublingual nicotine replacement tablet, which is there. There's also electronic nicotine delivery devices under development, other non-nicotine vaccine, which is the first group of them actually failed, but undergoing further development. So this slide, I'm not going to go over the details of it right now, but here's a quick and easy way of looking at it. And these things, basically, if you look at the bottom, it's a way to tell people that after you pool all the randomized controlled trials together, basically, roughly the most effective medication out there is Varenicline, and it doubles the odds of being successful compared to placebo. And so versus nicotine replacement also roughly doubles it. So essentially, medications to quit smoking are effective and roughly double the odds of quitting smoking. And I think that's something that patients should be made aware of, is that if you take medication, if you make a quit attempt, and all things being equal, if you take medications, you double your chances of being successful. This is another one which shows you, based on the medications, that, and if you look at this right-hand column over here, which is the idea that if you, sorry, I can't seem to move it, but if you have somebody who smokes 10 or more cigarettes a day, you have to recommend medication to them because the strength of the evidence is strong, which is one, and the quality of evidence is an A. So if you're not recommending it, you have to have a really good reason. The question of tailoring, again, is one where there's a strong recommendation, but the evidence is not very strong about tailoring. It's beginning to emerge, but it's not strong. Varenicline, again, has a 1A, very strong recommendation, and it should be offered to all smokers who are attempting to quit if they smoke 10 or more cigarettes a day. And if you're not going to offer it to them, then you have to have a really good reason as to why you're not offering them Varenicline or discussing that with them. Bupropion similarly is a 1A for short-term abstinence up to 6 months, and a 1B for 12 months abstinence, whereas Varenicline goes up to 12 months. Nicotine patch again is 1A, and the rest all go down from there. Because of the way we use the trials, clonidine and nortriptyline do not meet the criteria for recommendation, although they are available out there, and the U.S. guidelines do recommend them. So often people are saying, well, smoking cessation medications are very expensive, and excuse me, and I'm not going to spend for them. But if you get somebody to do the math, if they buy so-called cheap brands of cigarettes, and here's some of the brands out there, it's about $40 for 7 packs. Name brands will be about $66. But the name brand patch is only $30 a week. No name brand is about $20. And similarly, you can see overall, nicotine replacement is a lot cheaper than using that. And in fact, we haven't shown you the generic bupropion, but generic bupropion for a month works out to less than what it costs. But it's about $2 dispensing fee and about $30 for the month. So it's about $32. So it's really, really cheap for a whole week of bupropion. And but these are just giving a guidance to some patients who are wondering about the cash. And many smokers are caught up with cash flow, which is why we know that providing medication for free makes a difference. So, excuse me, when you look at nicotine replacement therapy, what is that about? What we are trying to do is help person in the initial phases of quitting is to help interfere with the ups and downs that nicotine causes as it's smoked. When somebody smokes, it has a half-life of about 90 minutes, which means it comes into the body quickly through the lungs, through the heart, and into the brain within 7 to 30 seconds, and then starts leaving almost as quickly as it came, such that in 90 minutes, only half of it is left in the body, prompting the person to take another cigarette. And so if you look at the national level, most people, on average, people are smoking 13 cigarettes a day. And, obviously there are variations, but on average, people are trying to maintain a level of nicotine. And they're trying to do that through cigarettes. So when people are quitting, we can give them nicotine either before, during, or after their quit date. And when you give it to them before, what it does is it's providing nicotine in a way that's interfering with the nicotine that they're getting from the cigarettes. That makes cigarettes less satisfying, and therefore therefore the person reduces the consumption, and therefore also allows for them to start stopping at the smoke so they can make a better successful quit attempt. If they've quit and then start the nicotine replacement, it really helps with the withdrawals in the early stages. And then after the first week, what we are hoping for the nicotine replacement to do is to help with preventing a lapse or relapse. So if somebody gets a trigger or a cue, has a cigarette or a puff, that doesn't give them the pleasure, and in fact they find it kind of gross and therefore don't do it again. So that's the whole idea between nicotine replacement therapy in the 3 phases. So before, during, and after somebody's stopped their cigarettes. On another aspect is it eliminates the toxic substances that one gets from cigarettes. So cigarettes have about 7,000 chemicals, 60 cancer-causing chemicals. NRT only has no cancer chemicals. It has nicotine in it, which is not known to cause cancer, but might be a cancer promoter, but not in the short term. And overall is why people smoke, but not why people die. So, it is really an important aspect to think about it as a harm reduction agent. So you're getting nicotine, but you're getting it in a way that's much cleaner and not through the lungs. It's most effective, obviously, when combined with counseling, and that's true for most addictive disorders and mental health disorders. Medication and counseling work better than either alone. But each one works independent of the other. So you can have people who respond to medication alone, can have people around counseling alone, but if they can do both, they do better. And so, I talked about this. It can be used to reduce smoking and to start before the quit date. Now, who should use an NRT? Not everybody needs medication. Not everyone can afford it. And for those who smoke 10 or less cigarettes, or less than 10, I shouldn't say 10 or less than 10 cigarettes, or 9 or less, or non-daily smokers, pharmacotherapy has not really been shown to be effective for that group and should basically be offered behavioral treatments. And again, but we need to assess a case by case as to whether some people might need pharmacotherapy or not. So what is the patch? So the patch is, again, there are 3 strengths that are available, 21, 14, and 7, and generally initiate at the 21 milligram for people smoking 10 or more cigarettes a day. For people who are sort of less than 10 a day and you've tried the behavioral intervention and they're still smoking, then we'll start with a lower dose. Or they're really tiny people and have not been smoking for very long, or having side effects of the 21 milligrams, we'll start with a lower one. And again, what we've also noticed is that with the patch, the overall duration is 10 weeks, and the first 6 weeks is you usually go with the 21, and then you go down to 2 weeks of 14 and 2 weeks of 7. But again, there's no good evidence that that's what we have to do. Roughly what we do know is minimum duration is 8 weeks. There is no real maximum duration, but we know that if people are able to maintain their non-smoking status for up to 100 days, they're much more likely to stay quit when you stop the medication. So that's how we manage the duration and individualize the treatment. The patch has to be applied first thing in the morning of the day, first thing in the morning. And the reason for doing that is that generally if people have slept, they have not smoked at night, and their levels of nicotine are low, so the patch starts kicking in. On the other hand, sometimes that may be if the patch takes about a couple of hours to reach full effect, starts working in about 20 minutes. Sometimes people aren't able to manage that withdrawal. But within a couple of days, if they keep it on for 24 hours, then that little bit of nicotine that stays on overnight through the patch is enough to keep them comfortable when they first wake up. Some of the common side effects that people have is that it interferes with their sleep at night, even if they put it on first thing in the morning, that they have vivid dreams. And so in those situations, we ask them to just pull it off at night before they go to bed. The advantages, there are really few contraindications. It's a once-a-day dosing. It has a steady state in the plasma, higher compliance, very low, almost zero abuse liability. There's not a whole lot of stuff that you can do with the patch. It's not something that you want to use if you want to get high. It's very so it doesn't have much of an abuse liability. Of course, the disadvantage is people have less control. So it's good for background cravings and keeping people out of withdrawal, but generally when people have an acute craving, it doesn't seem to mitigate that acute craving. It may prevent it, but once the craving occurs, it doesn't stop it. And the 21 dose may not be sufficient for everybody. In fact, if you're a pack-a-day smoker, at best with a 21 milligram patch, we simply cover only about 50% replacement. As I said, it takes longer to reach a peak. There are side effects from the skin, and sometimes if people are physically active or sweat excessively, the patch sometimes slips off, and so or if they shower in the middle of the day after exercising, it comes off, and so we have to work with them to make sure that it stays on, and whether it's putting some stretchable, breathable tape over it, that's there. And again, there's insomnia as an issue, and caution. It's not a contraindication, but caution with recent cardiovascular disease in the couple of days to weeks prior to initiating it. But if they're smoking, clearly nicotine replacement is a lot safer than continuing to smoke. Yeah, I think the other one, which is the first form of nicotine replacement, is the gum. Again, they come in 2 and 4 milligram strengths, and again, these are not to be chewed like regular gum. And again, the dosing is there, but you have to use it. The real important part is to slowly chew it only a few times and then park it. And if you're interested in looking at how these products are to be used, our YouTube channel at Teach Project actually demonstrates all the various forms of nicotine replacement. So I'll go over it quickly. And nicotine gum can also be used for harm reduction for people who are not interested in quitting smoking but want to use nicotine replacement when they cannot smoke, or to manage withdrawal when they cannot smoke. This is something that they can use. Again, the advantages of it is listed here. It's flexible dosing. There's more control. It's good for people who are not smoking on a regular basis. It's non-stick, sugarless, orange mint original. But for some people who have poor dental hygiene or have lots of dentures, it may not work as well and may not be recommended for that group. So it's more complex to use. If people chew it like regular gum and swallow all the nicotine, they'll end up with unpleasant taste or hiccups and dyspepsia. And with this gum, there are a small percentage of people who become long-term users and will self-identify as being addicted. The question is when when in situations where they've been brought off that, they'll go immediately back to cigarettes. So you know, we have to look at this group as a group that's probably maintaining the nicotine addiction and using it as a harm reduction tool rather than going back to smoking. The inhaler is not a true inhaler. It's actually, although you know this is the cartridge looks like that, and the cartridge looks like that. I'm sorry, I'm not able to do this. I was going to point at it, but the cartridge fits into this this black tube. There's also a white tube, but it produces a nicotine aerosol, not really a vapor. It's an aerosol that is absorbed in the mouth and throat. It doesn't go into the lungs, and none of it gets expelled. And generally, if it's a monotherapy, then it's 6 to 16 cartridges a day. So really 12 weeks of primary treatment and then tapering over 6 to 12 weeks, so a total of 24 weeks. And the cartridge should be used for about 20 minutes. Of each one of these single cartridges for 20 minutes is the equivalent of what one would get from a cigarette. However, many smokers will tell us that they don't need to finish the whole cartridge in one go. Should they tell you that, then let them know that the cartridge is good for about 24 hours after it's open, because then the nicotine degrades quite rapidly. And again, if after 4 weeks of using this, if they haven't been able to stop or completely replace their cigarettes with the inhaler, they need to check in with the health professional and see if they need to do something else. Again, it supports the ad-lib dosing, more similar to smoking. It has that hand-mouth coordination feeling and the fiddle factor that people may be looking at it. But the disadvantage, you must actively manage the treatment. You have to put it in. Some people don't know how to suck back on it and then land up getting a mouth and throat irritation. They don't like the taste of the menthol. They might experience it more expensive than the other forms of nicotine replacement. And again, some people with COPD might find it irritating and to their throats. But the other disadvantage is that people don't necessarily use it appropriately and end up underdosing themselves. Okay, so nasal spray is, again, I'm not going to spend too much time. It's really irritant. It's highly effective, acts very rapidly, but it's not available in Canada. I'm not going to spend too much time on that. The lozenge, on the other hand, is something that's available, and there are several types of lozenges, and there's even a 1 milligram lozenge, and it can cause a lot of confusion for smokers. But roughly, depending on brand, one brand is a 2 and 4 milligram, and the other one has a 1 and 2 milligram. And so roughly we ask people to use a higher dose if they are more heavily dependent, and in women tend to do better with higher doses rather than men. And again, you know, really the main issue when using the lozenge is no eating or drinking 15 minutes before use. And this is actually true for even the gum. Because if the oral cavity is alkaline, you get better absorption. And if it's acidic, by eating, drinking food, etc., you reduce the absorption of nicotine through the buccal mucosa. Again, as I said, it has that ad-lib dosing aspect to it and much more perceived control. The other thing is if people have poor oral hygiene or dentition, the lozenge does not affect that, and they can easily place it on their tongue and it dissolves. The disadvantage is, again, with anything short-acting is adherence, and again, people forgetting about eating or drinking, and they'll end up having their lozenges with coffee, for example, and then negate any effect of that. The mouth spray is the most recent nicotine delivery device. It's a 1 milligram dosage, and it relieves cravings very rapidly. It has a rapid onset of action. 1 to 2 sprays when cravings arise in the mouth. You just start off with one, see if you need the second spray, kind of thing. And up to a dose every 30 minutes to 1 hour, and each mouth spray contains at least 150 sprays, and we've demonstrated on our YouTube channel of how it's to be used. Again, really, you get really fast acting, and that's the whole advantage of it. The disadvantage is hiccup and throat irritation, as well as cost, and sometimes cost is a barrier for people to use this, one of the most effective nicotine replacement devices on the market right now. For all nicotine replacement, at least 8 weeks of therapy, and we know that people who take 8 weeks or longer do better than those who quickly stop. And we know that in real-world use, people are only using 2 weeks of nicotine replacement. In our STOP study, we've been able to get on average up to 12 weeks. But again, it's very important for people to understand that they need to take their treatment religiously and complete their treatment, and not to stop it just because, after 2 weeks they've quit smoking and they say, I don't need it anymore. Well, actually, they do need it, because that part of the cue reactivity where there are triggers and cravings, that continues. And so until they're onto that other part, close to that 100 days of abstinence, I don't recommend that they come off treatment too soon. And that's the biggest problem, is treatment fails because people don't take it, or don't take it for long enough, or in the appropriate dose. Bupropion is an antidepressant. It doubles the chance of quitting. It minimizes the weight gain associated with quitting smoking. Of course, it is available by prescription. You have to be careful with people who have had seizure disorders, active eating disorders, or medications like MAO inhibitors. They're using bupropion or sensitive bupropion, or in some parts of Ontario where there is inexplicably an abuse of bupropion, then you'll be a bit careful about giving it to those people who've had a history of it. But for the most part, that's the only few case reports in Ontario which have come out. Nowhere else in the world have we seen this. But so I would just say, if you're in those parts of Ontario where this does occur, usually in the northwest part of the province, it is something to be mindful of in prescribing this medication, and definitely speak with a pharmacist about if there's any concerns about it. It doesn't work because it's an antidepressant. In fact, it works by interfering with the experience of smoking, and in fact blocks the pleasurable effects of nicotine by competing with nicotine at certain receptors in the brain. With this medication, you need to wait for 7 to 10 days, or at least on average, but 14 days, after the person starts the bupropion. So they start the bupropion, then they try to quit, and usually people should try to make that quit attempt within a couple of weeks of starting the medication. After about 7 weeks, if they haven't had any reduction, then it doesn't make sense to continue it, and they should be discontinued, and roughly treatment should be about 12 weeks. They don't need to be tapered. The advantages for people who feel like they can use it while smoking, and this is sometimes an easier one for those people who want to gradually taper off rather than stop abruptly. And both work. The advantage is there's less weight gain with this medication. In fact, bupropion in combination with naltrexone is used as approved in the U.S. for weight loss. So it has that advantage, and it also may be a best choice for people who get kind of depressed when they stop smoking or have current depressive symptoms, and it can be combined with other antidepressants. But certainly if you see somebody who's interested in that, have them speak to their doctor or pharmacist about it, or nurse practitioner. Again, we can't give it to everybody, because if people have had a history of seizures, then it's not important. It can't be given to them, or if they have an active eating disorder. And these other ones are obviously common sense. If they're taking it for depression, then they can't get it. And unfortunately, some people don't know that, because bupropion is, for depression, is called Wellbutrin. For smoking, it's called Zyban. And sometimes if you don't ask specifically, they may not tell you. So we always ask whether you're taking Wellbutrin or bupropion to make sure we're not double dosing them. The latest kid on the block is a medication called Varenicline, which was inspired by the observation that cytosine, which is a medication that is a chemical compound that comes out of a tree, laburnum plant, that actually blocks these receptors. The alpha-4 beta-2 nicotinic receptors acts as a partial agonist and reduces the withdrawal and craving for cigarettes. So essentially, Varenicline has been designed based on that, and you can see it works very specifically for that, and it's an oral medication. It reduces the craving and withdrawal, and it basically blocks those pleasurable effects of smoking. Again, it has to be started in the way that's described there, and I won't spend too much time on that, but what it does do is, again, allow the person to ease into quitting after a week after starting it. But we have noticed that people can quit up to 12 weeks after starting it. And so if people are, we'll check in with them. Some people say, oh, well, I've reduced them down to 2 to 3 cigarettes a day. But keep going with the medication because eventually they stop. And so we've seen people stop up after 8 and 10 weeks of starting Varenicline. Again, it's easy to use because oral tablet twice a day. It starts while the person is still smoking, and it does not interfere with any other drugs. The body does not metabolize Varenicline, so it comes into the body and it gets excreted by the kidneys. So it doesn't have any important drug interactions. Clearly, there are contraindications. If somebody's allergic to it or gets a skin reaction, then you've got to stop. Sorry about that. There is a black box warning about safety. So there are case reports in the clinical trials. They weren't able to find this, but there are issues around whether people get neuropsychiatric effects, which are depression, suicidal ideation, suicide attempt, and completed suicide. But it is not necessarily because of the Varenicline. It could be the withdrawal the person is because of when they're quitting smoking. And it is not clear, and current studies are undergoing trying to figure this out. What we do know for sure is that it's a rare event. It's not a common event. What is a common event is that most people who smoke will die from smoking. So that is a common event. This is a rare event. And so you have to balance the risk-benefit when using these very effective medications. So the other issue is that there are other effects that we understand from post-marketing is that there have been small number of cases over the 5+ million prescriptions. There have been a very small number of cases. So people who combine alcohol, they'll end up having a sort of blackout and they don't remember what they did. So although Varenicline is being studied for treatment of people who drink and smoke in excess and might have some early benefit, these are some of the things that have been noticed, is that they lose their tolerance to alcohol and might become aggressive. So it is something to tell people, is like if you're trying to quit smoking, anyway, you shouldn't be drinking alcohol when you're trying to quit smoking because alcohol is a trigger to smoke. So it's important to not drink when you're trying to quit and reintroduce alcohol so that it doesn't act as a trigger to go back much later after you're much more confident that you've been able to quit. And again, the issue of seizures is a rare event. So in the millions of cases, it's a rare event. But these seem to be new onset cases of seizures. And so these are some things that we have to just be mindful for, but they are rare events. So what we recommend is obviously reduce the amount of alcohol or stop alcohol, weigh the risk benefits of seizures, and again, monitor the person while they're on Varenicline and discontinue it if they have any problems, obviously, and report it to Health Canada. What we do is we screen everybody for their mood before we start these medications. When they're quitting smoking, we check for mood because it's such a common problem. So we use something called PHQ-9 and ask these questions about their mood and suicidality. And if it's okay, then we just let them know we're starting a medication. If watch out for any of these behaviors. If they immediately stop the medication and get in touch with them. Make sure they read the medication guide and then report any of these adverse events to Health Canada. So Varenicline is the most efficacious and effective drug, and roughly has been used in multiple populations, including those with COPD, depression, schizophrenia, and but it's not completely benign, and no drug is completely benign, and so you have to balance the risk versus benefits. The other option is combining medications, and so there's not many studies looking at Varenicline and Bupropion. I think there's only one, and finds it to be safe. But what is really important is that in this open label study, you could get 71% of the patients who they had were able to stay abstinent, and further research is required to see who requires long-term combination therapy of Bupropion and Varenicline. So that's an overview of the medication, and here, I don't expect you to read this on the slide, but I just want to show you this algorithm that puts it all together in primary care settings and could certainly be adapted for the dental setting. roughly, if you look at the left-hand side, you can see the ask, advise, assess, assist of the 4 A's, and it really guides you through the various steps depending on the response. And then over here at the bottom half, you can see that you can include cold turkey as a way to quit, reduction to quit, and abrupt cessation, and see whether medication and counseling is required, and what are the medication options, and what to do after, how to arrange follow-up, and what to do if they haven't had a response or a partial response. So that's roughly that guide. And here's a little bit more detail. You can see the ask, advise, assess, some information about quitting and smoking and weight, the need for motivational interviewing, especially if there's higher ambivalence where they aren't that ready to quit. That shows you how to proceed. In terms of first-line pharmacotherapy, in our guidelines, we decided to go with what's known as the safest, which is nicotine replacement. As we know is the safest. It's been around the longest. It's over the counter. It doesn't even have a DIN number anymore, so anybody can buy it and anybody can sell it pretty much. And so we started with that and then went on to the most efficacious one, which is Varenicline, followed by Bupropion. And so even though there haven't been any, or there's just 1 or 2 head-to-head trials, they don't really tell us which ones should start with first. But certainly, these are the options. These are the first-line medications. We must see the patient in 1 to 4 weeks post-quit date, and then see if they've had a full response, and then just go to maintenance and finish the treatment, and follow them up to make sure they haven't relapsed. So if they're lapsing, then reinitiate treatment. But if they've had a partial response, assess whether they're adherent to the medication, adjust the dose, increase the counseling, or modify pharmacotherapy if needed, and that may be combination. And so whether you use the combination of Bupropion and Varenicline, Bupropion with nicotine replacement, or 2 forms of nicotine replacement is one option, or switch. If you are nicotine replacement, you could go to Varenicline or Bupropion or any set of directions that you can undertake to help the patient quit. So in a very quick way, we've run through how we think about medications, and so the role of medications is to help initiate a quit attempt, to help people quit, to manage withdrawal, to then interfere with the habit part where cues are causing them to relapse. It helps do that. What medications don't do in the long term is help people manage stress-induced cravings. And clearly that requires behavioral treatments that help people understand that. And lastly, we know that medication, there is a level of motivation that is required for medication to work. In the absence of motivation, medications lose their effectiveness. So that's the summary. And I think we can open it up for questions. I'm going to see if, before we open up for questions, I'm going to see if Dr. Saunders wants to say anything.
Okay, so I hope everybody can hear me now that I'm on the phone line. We were having some problems with my audio on the computer, and I apologize. Let's go to the case example of Mary and just maybe refresh some of the comments that Dr. Selby said over the course of the last half hour. Duration of any kind of counseling or nicotine replacement is important, and the whole impact of us being part of that journey with the patient involves us booking follow-up. If we're talking about a private dental practice or a hospital dental program or a hospital program, you know, initiating that talk about asking and assessing and advising their smoking history and inviting ourselves to ask if we can participate in that journey with the patient, I think is very important. Booking a follow-up is important, like Dr. Selby said, within 1 to 4 weeks, especially if pharmacotherapy or nicotine replacement is being discussed. So let's look at Mary and keeping all of that in mind, how we would address and maybe even how we would approach Mary in a private dental practice and having a cleaning or seeing the dentist. Obviously, most of our patients we've been seeing for a number of years. Some of us may only have started to have an interest in a clinical tobacco intervention for our patients. So this may have been already the 20th visit that Mary's been to the dental office. So obviously opening that discussion and addressing her smoking history, if you haven't done it before, is going to take some creativity, but it's really easier than you think. So Mary's in, her chief complaint is some stained teeth. You're noticing unresolved periodontal disease time and time again after seeing her going through oral hygiene, and still there is no management with her periodontal disease. One of the opening comments that you could have is just saying, Mary, I noticed that you have been a smoker for the last number of years. How much are you smoking right now? If she relays to you that she's been smoking over a pack, of which we know Mary has, then just invite yourself to be able to ask her a few more questions about her smoking before you address the stain issue. That's a way to kind of get into the discussion with the patient if she's receptive, and then addressing some of the common oral conditions that we see in patients in the dental practice related to chronic tobacco use, and one of those is definitely uncontrolled periodontal disease. So we know Mary's 50. We know that her marital status is divorced. She smokes in the car and in the apartment. Those are definite places where to avoid triggers is a way for habit reduction. But looking at the amount that she's smoking, and from what Dr. Selby said at the beginning of the lecture, that the evidence base is out there. There has been some very good research to confirm that if patients are smoking over 20 cigarettes or over 10 cigarettes a day, pharmacotherapy or nicotine replacement is very important. Looking at her medical history of COPD and thinking of a nicotine inhaler probably is not going to be the best for her. I always encourage patients to consider pharmacotherapy first because we know the success rates are 3 times higher than that of no pharmacotherapy at all. And part of that discussion with her today is going to be addressing her tooth staining, but more importantly what you're seeing as the dental disease that she has, how her smoking history is linked to her medical history of her COPD, and then just ask her to openly give her thoughts on what her thoughts are on about how the smoking is related to all of this. So Mary has opened up to you. She's letting you know that she has had to go to the hospital on a few occasions for her breathing. She does state that she is aware that her smoking is related to this and that she has been advised by many healthcare professionals that quitting would be advantageous. She's had some failed attempts in the past, and we know that most smokers, before they finally quit, 7 or 8 failed attempts are usually within their resume. So we know that we can reassure the patient and congratulate them that they've gotten to the point where they've wanted to quit, and that their failure is not a failure for life, but it's just an initiation to try once again and invite yourself again to be part of that with her. Now, when we look at her importance of quitting, she definitely knows the science. She knows how this is impacting her health. She knows that there's a 10 out of 10 importance for her to quit, but it's her confidence that is low. And sometimes when patients have a low confidence, sometimes it's better to ask them, well, what makes your confidence level not a 1? Why are you at a 4 and not a 1? Instead of saying, well, why are you not at a 6? So she may relay to you why her confidence is low, and most often it is because patients have had unsuccessful long-term cessation attempts in the past. That's when addressing to her that, most smokers quit 7 or 8 times before fully cessating, and wondering if that could increase her confidence level because she has had some quit attempts in the past. So maybe some discussion for Mary going forward, and some comments that have been typed in throughout the course of the webinar today is what would be best for Mary. Would pharmacotherapy be best for her? Would nicotine replacement be best for her? And asking her what her thoughts are on that would be beneficial. CAMH and TEACH has a really good algorithm on the different side effects, the success rates of all different uses of nicotine replacement and pharmacotherapy. And sometimes using just what we've discussed at that first appointment and then booking her in for a follow-up to see what she's read up and what she thinks she'd like to attempt next can be the most effective. So we should probably open up the talk there, Dr. Selby, for any questions that the group may have. Do you have anything to add?
No, I think that's a great point. I think one of the things that we need to look at, going back to Mary's case, is that she's smoking quite heavily, at the 30 to 35 cigarettes a day. And standard level pharmacotherapy of nicotine replacement might not be effective for her. So single monotherapy might not be effective for her. The other thing is that she's already got end organ damage like COPD. And as you rightly pointed out, she's got, she sees it's important, but she's not very confident. So, you know, and she's tried the patch in the past. And again, you know, in these situations, thinking about these questions, the patch in the past may not have been adequate, and therefore, if she wants to use the patch again, we need to think about some combination therapy there too, and those questions have been set aside for that. So I think it's really, I wanted to orient you to that, and I think you made a really good point about saying, well, if she's smoking in the car and indoors, then how do you make that smoke-free? And I think that's a key part of the plan. It's not just about the pharmacotherapy. So should we just go to the questions that I think people have already typed up? And
Sure.
Colette says that if a client who smokes over a pack a day begins with the 21 milligram patch for 2 weeks and wants to switch to Champix, would you recommend they keep the patch on until the Champix builds up in their system? And the way we answer that is no, because what happens is the nicotine that comes out of the patch creates a steady level for 24/7, and you know, when you put a partial agonist like Champix into the mix, it can precipitate nicotine withdrawal, and so when they've done that in the past, people land up with more what they call side effects, and in fact they feel much more irritable and agitated, and etc. So if the person is on the patch, take the patch off, maybe the evening before, let them go the whole evening. If they have a cigarette, they have a cigarette, but then start the Champix first thing the following morning, giving the nicotine levels to be relatively low so that when the Champix comes in, it has a place to act. Using the brand name Wellbutrin for smoking cessation, you know, it's exactly the same drug, and so using that dose of 150 milligrams twice a day is, whether it's Wellbutrin or not, doesn't make any difference. The brand name, this is the same manufacturer for Zyban and Wellbutrin, and so it's kind of a moot point in my mind. The main thing is not to use the two together. Colette also asked a follow-up question about clients using e-cigarettes with nicotine. How do we determine where to begin with NRT? Are there guidelines for e-cigarettes with nicotine? Actually, no, because we don't know whether the levels of nicotine that they're getting from e-cigarettes are what's stated. I mean, it can say 0 milligrams of nicotine on the e-juice, but have nicotine present. It can say 18 or 24 milligrams of nicotine per ml on the e-juice and have none. So really, there's no way of knowing if you're going to use NRT. And again, you know, my question is, what's the purpose of using NRT in somebody who's using an electronic nicotine delivery device? Because we're not really sure. And in those situations, if anything, I'm much more likely to use Bupropion or Varenicline, because at least I know I'm not trying to mess around with what nicotine they're getting. And if they do get a side effect, then I know it's not because of the medication, because of the nicotine I'm giving them. I have no way of knowing. Because the other thing is they're using e-juice today, which says it's 8 milligrams. They go back to the same vendor, and then the next week they get, because there's no quality control, they're getting 18 milligrams. So yeah, I think I'd be really cautious in using nicotine replacement therapy with somebody who's using an electronic nicotine delivery device currently. In the 70-plus age group, we use nicotine. If they're smoking, I have people who are in the 80s. If they're smoking, then they get nicotine replacement just because it's, you know, we try to match up to what they're getting, because that's what they get. So we don't make any cost reductions. With Varenicline and Bupropion, you do mostly Varenicline. You may need to use a lower dose depending on the kidney functions as they are much older. But and Bupropion again, you may need a lower dose in them just because of the way they metabolize medications. Why are some people in Northwest Ontario abusing Bupropion? Good question. We have no idea. It's actually not a good drug to abuse because it causes, when they inject it, it causes major necrosis of where they inject it. It's not clear. Now, Bupropion might have a mild stimulant effect, but the doses in which you can get that stimulant effect seem really not well reported in the literature. So it appears that may be just some reasons to abuse something, and that's what they find they're going to abuse because it has a stimulant activity.
We have one on the e-cigarettes there, Peter.
Yeah, how do you feel about e-cigarette usage only as NRT? Is there any studies that note success? Yeah, there's been a couple of studies from Australia, New Zealand and others that have done a meta-analysis, and so, they were poorly done studies using first-generation e-cigarettes, which did contain nicotine, and legally in Canada, e-cigarettes cannot contain nicotine, and so the first-generation ones, which are not refillable and disposable, technically they don't have nicotine in them, and it's the ones which are refillable, where you get e-juice and you have to put the juice in. Those are the ones where nicotine comes in. So as it stands now, if we got highly regulated, good quality systems that delivered nicotine, they might be a good option for people who are unable to quit using standard treatment. And so jumping to electronic devices before people have tried and not responded to existing devices seems a bit premature. Secondly, if people have never tried to quit using any other means and then putting them on e-cigarettes right away, where they might continue to take that for life, that makes no sense. So really the rough point in Canada is that it's not regulated in a way that I'd feel comfortable. There's no quality control that I can point to and say, yeah, I know that if I'm saying to you, you're having this electronic device with this company, that today the quality is good, tomorrow the quality is going to be good, and I know somebody's checking to make sure that what they say about quality is being maintained. So theoretically, I think it's a great idea, but I don't think we are there yet.
Sorry,
go ahead.
So, I've done a little bit of a literature search on the statements from all the medical professions, including the dental hygiene organizations and dental and medical, and really the position statement is that we really, as healthcare professionals, can't recommend the use of electronic cigarettes in Canada because it's not regulated, especially those that contain nicotine, and that's usually the frequent message that I give my patients. But obviously, I'm hearing from you also, Peter. It's a form of nicotine replacement, not regulated. There was a recent study that came through Harvard only a couple weeks ago, and I haven't had a chance to read it, but it was discussing some of the potential harms in the flavorings that we're always wondering are these safe products. And I'm interested to read that study, but it does appear that some of the flavorings are actually not safe.
Yeah, so the flavoring, and that's the issue from product manufacturing standards. The flavorings actually, especially the diacetyl, is a flavoring that, which gives you your buttery popcorn flavor. That is potentially dangerous. And there's the cherry flavor, which is also not good. Mm-hmm. There may be some effects of the propylene glycol as well. Although generally considered safe for inhalation, although it's a mild irritant, taking it in the volumes at which people who vape do may have long-term effects. So I think before we jump on the bandwagon, we do need to first better identify who should be using it, under what circumstances, and for what purposes, and what shouldn't be in them. So these are early days, and things need to be sorted out. And for example, electronic cigarettes that explode, again, a problem. Those are problems of quality. They're not problems that haven't been fixed before. these batteries that are used are lithium-ion batteries. They're the same batteries that are in our computers and our laptops and our phones. But they're used. The quality of the batteries that are used in our phones and our laptops are very different than what is currently being sold in electronic devices. And so it really speaks to the need for regulation at a national level for it. Okay, let's move over to some of that.
Let's go to the last question so that we can show everybody what kind of resources we have and what's coming up. There was a good question by Claude. Who can prescribe NRT? Physicians, dentists? Like Peter said, NRT, nicotine replacement, is available over the counter, so it does not require a prescription. But for those that are trying to get it covered through their drug plans, physicians, dentists, and pharmacists can prescribe it. That's the value of having a dental team involved, like we've been talking today, having all staff on board with clinical tobacco intervention, and then being able to offer pharmacotherapy as the dentist can prescribe that. I think it's a real value for our patients and really is the prime focus of this series of webinars that have been set up. Now, moving forward, what we have available through the Ontario Dental Association is patient readable materials that are promotable and available in the waiting rooms through our dentist offices, but also fact sheets that have also been posted on the CAMH website. These are available to download also on the Ontario Dental Association website. And they're tools for us as dental clinicians and dental professionals to give to our patients as openers to provide further information, further help, further support, but also educating the patient on what certain aspects do we see as changes in the oral cavity that can lead to or show increased risk in certain types of cancers. And I use this oral changes associated with tobacco use fact sheet on a daily basis as I run an oral diagnosis clinic within my practice. It really actually opens up the discussion for patients never thinking that they needed to quit, but some of these oral changes showing real high risk for development of certain types of cancers, and I find it really educational for the patient. These types of posters and very similar ones have been done through other medical associations. This has been worked up by the Ontario Dental Association. I have this poster in all of my operatories. Obviously, patients do wait for us at times. It's something for them to read and ponder on while they're waiting, and allows them to educate themselves while we're not even there. So through this coming year, 2016, the Ontario Dental Association's information campaign for the public and professional is our world of dentistry, but how that relates to our ability to help our patients quit smoking. And there will be journal abstracts throughout the year in our Ontario dentists. But more importantly, Dr. Selby and myself will be co-presenting at a 3-day symposium this May in Toronto. That has been developed by CAMH in conjunction with the Ontario Dental Association. And we hope to see the dentists and the dental hygienists participate in this symposium because it will be dental-centric. Just to kind of whet your appetite, I think was part of the series of webinars that Dr. Selby and I had hosted over the last 2 months. So are there any further questions?
I just posted the link to the study on the cherry flavoring, and there's another earlier studies that have come out with respect to the diacetyl, which is not the benzaldehyde. So hopefully you find that helpful.
Thank you very much, Peter.
Thank you very much, Debbie. Okay, so I think it's 1 o'clock, and I think if we don't have any more questions coming through the online thing, I think I want to really thank you for your leadership on this, Debbie, and thanks for everything that the ODA is doing as well as everything else the dental professional is doing to keep this top of mind, and we're really happy to be partnering with you on this. And thanks everybody. I think the 113 people who signed up today. So
great.
Thank you.
Thank you, Dr. Selby and Dr. Saunders, for a great presentation today, and thank you to everyone who joined us. We hope you found the session very helpful. Please remember that a link to the evaluation and post-learning assessment will be emailed out to you today by end of day, and it is a requirement to complete the post-learning assessment in order to receive your letter of completion, and you will have 1 week to complete that. As well, if you attended today's webinar as a group, please do remember to email us at teach@camh.ca with a list of your group names. Okay, thank you very much, and I will try my best to include as many resources that were mentioned during today's webinar in the follow-up email as well. Thank you, everyone.
Thanks, everybody.
Bye for now.